Hi, my name is Dr. Jennifer Young. I'm a community family physician in Collingwood, Ontario, and have been practicing here since 1999. Before that, I was in a few other countries and did my training at U of T undergrad, and then Ottawa U for my family medicine. Here in Collingwood, I'm a clinician who has been doing a fair amount of stuff in different areas. I continue to do emergency medicine as well as hospitalist care for my practice, low risk obstetrics. And I have a really strong interest in choosing wisely. And in some ways, that's what has helped me to have this increased interest in quality improvement and a little bit in research. And I'll get a little bit more to that later on. So one of the things that our practice is a part of, my practice is a part of the Georgian Bay Family Health Organization and the family health team. That's it is a has the PS Suite is our electronic medical record. And I bring up that because it's very hard to do quality improvement and to do research when you are not on an electronic medical record. It's a challenge for a lot of busy clinicians who don't have a lot of administrative support to do quality improvement, because the time it takes to do searches and get your database functional is challenging. It means putting your information in a standardized fashion, being able to search different conditions in ways that are easily accessible. The electronic medical record that we have in our hospital, and I'll get to that as well a little bit later, is called Meditech, and we are just about to change into one called Meditech Expanse. And different electronic medical records allow you to do your data collection in a more efficient way. And we are certainly hoping that our Expanse is going to allow us to collect data in more efficiently, to be able to do quality improvement and research projects without as much laborious manual auditing. So I'm going to start back to my practice and the kinds of things that you can do within a practice around quality improvement. And I just wanted to share with you there is something being put together by Health Quality Ontario, which is a non-governmental, but it's associated with the Ministry of Health. They create my practice reports, and I'm just going to share my screen with you to show you what that looks like. Every family physician and surgeons as well are getting these. These are available to them, and they are updated twice a year using the data that is administrative data. And what it does is it reports on things. I'm just showing you the main page here, but you can see that I've been getting these reports since 2016. And it reports on things that are my opioid prescribing, how many are new starts, how many are associated with benzodiazepines, how many patients of mine have opioids started by other people. It shows me the trend in my opioid prescribing over those years that they've been collecting data. There's also a section on cancer screening where it gives me a report on the screening for colorectal cancer, for cervical cancer, and for mammograms, which is for breast cancer. There's a section on diabetes that looks at my measurements around diabetes. And then it also gives me a section around my health service utilization, which is a reflection of my whether my patients can come in to see me, or whether they see the proportion of primary care visits that are to me, as opposed to, for example, a walk-in clinic or another clinician. It gives me hospital readmissions within 30 days, within a year. It gives me an idea of how sick my practice is, and then also lets me know how well my group is looking after my patients. So it's within that report, there are, after each section, there's suggestions and advice around how you can do your own quality improvement within your own practice. The other thing I wanted to share, so I'll just stop sharing, and just to let you know as well that the College of Physicians and Surgeons of Ontario is the college that gives us our licenses, and gives all physicians their licenses, family practice, surgeons, psychiatrists. They're the ones who who monitor the high level quality of the stuff that you do. And so you have to be like really bad to have them interfere with your day-to-day work. And the hope is that they are there to ensure that we are providing high quality care for the people of Ontario. What they have done in the past is have people come into your practice every 10 years and have a look at your charts. But it's evolving into a new way of monitoring how you're doing. And that is asking clinicians to do their own quality improvement or show their own quality improvement projects. So I mention it just because quality improvement up until now has been kind of seen as a for the average family doctor, seen as a voluntary thing, not something that is necessary as part of your ongoing year-to-year practice. It's been encouraged. It is becoming something that is more than just encouraged. It is something that is going to be required, I think, in the longer term. And so it's important for all of you as new and young clinicians to be thinking about your practice with a quality improvement lens, and have that as part of your month to month, year to year sort of activities, where you say, hey, I'd like to look at a certain part of my practice and see how I'm doing. And if I'm doing not as well as I thought I was, because you don't know until you look, what are some ways that I can improve? And it is a given that all of us have room for improvement in the way we do our work. So then you do your, what we call a PDSA cycle, where you look at the issue, you make a plan about what you think you can do, you do something different, you then look at your data again, and if there's an improvement, great, keep going. If it could get even better, then you act and make another one. So that plan, do, study, act, which is the circle of quality improvement. And one of the things that I want to also say in that is that it's not just a single circle. You don't get it right the first time. Quality improvement is about finding small tests of change. You might make something a little bit better. You might then look to improve and add on that. And then it's a wheel rolling up a hill, so that eventually you're at a place where you think, gee, I don't think I can get too much better in this. But it is a circle of not getting it quite right, doing it a little bit better, doing it a bit better, as things improve. The other part of quality improvement is that it's very rarely a single person's job to do it. When you look at how things are being done, or maybe not being done perfectly, you could look at all the different things that might be making it difficult to have that outcome that you think is ideal. And that usually involves your team looking at how can the other parts of your healthcare team who you work with, for example, your reception, your office nurse, your other colleagues, look at what are some factors that are adding into less than ideal outcomes. So that whole quality improvement is a team effort. It's something that looks at multiple factors, that expects to not get it completely right the first time, but don't get discouraged, because getting it better is getting it better the next time. And that's both the College of Physicians and Surgeons of Ontario and Health Quality Ontario absolutely encourage us to be curious about our practice. They don't expect us to be perfect, but they do expect us to be curious and committed to improvement. So that's at your practice level. I was also involved in our family health team, and not every family physician in Ontario has access to a family health team. And I'm one of the 25%, 30% of family doctors in Ontario that presently have one that works with her. And that's very helpful because there are usually people who, within that family health team, who can be that administrative support around doing searches and getting information out and making charts and looking at the organizing meetings and just that kind of, keeping you on the ball around an activity or a process that you've gotten started when you're busy with your other clinical stuff, like seeing patients in the hospital and in your office and emerge shifts and delivering a baby here or whatever it might be. So having admin support has been made easier by working within a family health team. And our family health team took on a number of things where we were looking at reduction in antibiotic use at our after hours clinic, where we were looking at use of proton pump inhibitors and reducing those. Reducing opioids, reducing the unnecessary testing. Also looked at things like improving our PAP screening and our PAP tests and our colon cancer screening. We created some posters for the research day, and the romp, as you can see in the back, is part of the Collingwood General and Marine has sponsored 6 research days that have showcased the research and quality improvement projects that have been done by various partners in our community. So this last year, for example, our family health team was focused on the COVID response, of course, and those were getting our vaccine clinics, getting our testing, getting our COVID home monitoring program, which was just fantastic, and we did a great job. And then also that's spun off with into the our Georgian Bay. Our area is going to be connected to an Ontario health team. And that learning from that is going to go towards our ability to help people who are perhaps frail and homebound, and how can we help to access them. So it's a good example of doing one activity in one area and then ending up doing it, popping off into a better activity or a similar activity for another target population, which are our frail elderly. So then the other thing that I wanted to talk about was our hospital. And in the hospital, I was the chief of family practice for 6 years, and during that time was involved in trying to get quality improvement projects going within the Department of Family Practice, or medicine essentially. Because most of the people who we don't have a hospital where the specialists are in charge of their care unless it's surgical care. It's always a family doctor who's in charge of who's what we call most responsible physician. And so the Department of Family Practice, it does a lot of the medicine, the MRP for medicine patients. We have a quality improvement committee, and we have a matrix where people can submit their ideas around quality improvement projects, and then through that people are assigned, students such as yourself, and I'm sure some of you've been involved in some of these projects. And one of the challenges that we have is that we don't have year-round students, and we don't have and that makes it more challenging to do a project that would be throughout the year. We're concentrating a lot of our efforts have been during the summer period. But as we have more and more learners who are involved with our specialists and family physicians, and our own residents who are part of our community, we're encouraging them to look at quality improvement projects that are already ongoing and already a part of the priorities of the hospital or the family health team in order to further those inquiries. I did allude to the challenges that we've had within our medical system, or not our medical system, our medical record. The Meditech has not made it super easy to get a lot of data easily. And so many of our projects rely on individuals going into charts and getting manually the information that they need out of it. For example, doing even an audit around blood transfusions and reducing unnecessary blood transfusions, it was really a challenge to get the hemoglobins that were being the hemoglobins that prompted the transfusion, and then the number of units that they got, and whether they got a hemoglobin test after the first unit. So these are components of good quality transfusion practices that it was very difficult to measure how well we were doing and whether it was a problem, and then how well, what we could do to improve it. So that our Meditech expanse is likely to, well, I'm sure, and given the amount of digital, that everything is basically digitalized, we will be able to do QI and research in a much easier fashion. So I have mostly been talking about quality improvement because in a community setting, that is mostly what we do, because research is far more challenging when you don't have an academic infrastructure around you. That being said, many of us in our region have signed up for SIPSN, and I'll share my screen again. And you've probably heard about SIPSN because it's, I have noted some of the speakers are my esteemed colleagues who do that challenging thing of research. But SIPSN stands for the Canadian Primary Care Sentinel Service Survey Network, big long acronym. And Utopian from the University of Toronto is a part of that. So SIPSN is across the whole country, and U of T is coordinating the sort of central Ontario group of practices that are involved. There's another pod of researchers around Kingston, and I believe another pod around the London area. So this is Utopian, is the U of T practice-based research network. And what that allows us to do is, when I sign up to that, my data my practice goes into this large database that can be used by primary care researchers who are looking at various other questions around disease states and how they're managed in the community. So, there's research where you have all of your variables are controlled, and then there's just practice where this is how it works in the real world. And that's the kind of research that's being done in these practice-based research networks, where they will ask a question about epilepsy, and they will take the epileptic patients of all of the family doctors who are working in their network and who've signed up, and have a look at how they are, what medications they might be used, what sort of monitoring is being done. I use that as an example. I don't know whether that's a specific project, but that would be the kind of thing that could be gleaned from your practice database. And what they have is a system of taking your data and cleaning it, so to speak, i.e. making the stuff that I've written in my notes and might not have coded in a specific click into that spot, so that it's a unique data point. They're able to get information from the written stuff that I might put into the charts, and the various different ways that I might have entered in the problem field, might have entered that they have hypertension, whether I wrote hypertension or HTN or high BP. Those kinds of things are done in various ways in different family practice offices. kind of talking about that standardization is a challenge when you're dealing with all these 13,500 family doctors in Ontario do not do all of it, do not have their office charts organized in the same way. So I'm showing you this, I'm showing you the utopian information about utopian, and you've probably seen this. And anyway, Mike Evans has a nice YouTube video around primary care research and utopian. And this video here is Dr. Francine Lemire. She is talking about the National College of Family Physicians, and they're encouraging primary care research through the Canadian Primary Care Sentinel Survey Network. So my involvement in research is mostly that way. I have signed on to SIPSN, and you can also sign on to various other projects. There might be individual physicians from other areas around Ontario who might ask you to participate in a project. But in Collingwood, none of us are really doing our own research projects that aren't based in the hospital, and more or less quality improvement projects. So that's kind of my presentation in a nutshell. I'm a community family doctor and love doing all the different clinical things that I do. And sometimes putting quality improvement into a really busy clinical life is a challenge. Having a good electronic medical record that allows that, enables it easily so that searches are intuitive, is helpful. There is an e-health center for excellence, which is available to all physicians in Ontario. And they have helped to create searches that have been tested and found to work. So you don't have to reinvent the wheel. And it looks at it helps you also to see what other people are doing in terms of their own measures within their practice. So having things that enable you to do quality improvement is really important, but also going into it with this attitude of, this is part of my day-to-day, will be a part of my day-to-day, maybe not day-to-day, but week-to-week, month-to-month practice, where I'll take some time on a monthly basis to reflect on how am I doing on a certain area, and how can I improve, and how can I work with my team to make that kind of improvement. So I thank you for your interest in research and in quality improvement, and I wish you all the best in your careers, wherever they may lead you. It's a wonderful profession that we have been honored to be a part of. So I hope that you embrace it and thrive in it. Find ways to stay curious, stay compassionate, and do great work. Bye for now.